interesting talk coming up. I would like to introduce Kara Ayers, who is going to introduce our next speaker.
Thank you, Dr. Tosi. So I'm happy to be with you all today. I had to pop on just a few minutes after you started, but this topic is close to my work personally as a person with OI, but also professionally. I sit on the board of governors for PCORI and have really learned so much about patient-centered outcomes research in the last couple of years. So without further ado, I'd like to introduce Dr. Bryce Reeve. Dr. Reeve is a professor of population health sciences at Duke University School of Medicine. At Duke, Dr. Reeve serves as director of the Center for Health Measurement. Trained in psychometric methods, Dr. Reeve's work focuses on assessing the impact of disease and treatments on the lives of patients and their caregivers. Dr. Reeve serves as a co-lead on the OI Foundation's PCORI Award, Improving Patient-Centered Outcomes, Expanding Engagement of the Osteogenesis Imperfecta Community. Thank you so much, Dr. Reeve, for being with us today.
Thank you so much, Dr. Ayers. Can you all hear me okay? Great. Okay. Very good. All
Can
right.
you be just a little bit louder, Bryce?
Let's see. Is this better?
Yes, thank you.
Great. Thank you. And feel free to let me know if I am speaking at a lower tone. I'll switch off my mic and go to the regular phone if I need to. All right, so for those of you, you don't see my video, but you might be seeing my picture. I like this picture because it's at least a decade or more old. It makes me feel young. Also, because of the coronavirus quarantine, I have shown my inability to shave, and so I could probably try out for a member of ZZ Top. And so again, that's probably a good reason not for you to see my actual video. Let's see, so hopefully you are seeing my slides. Let me go over to slideshow. Let's see, very good. All right, so let's go ahead and get started. So thank you so much for that wonderful introduction, and thank you to the OI Foundation for allowing me to talk to you all today about a subject I'm very passionate about, which is measuring what matters. And so for today's talk, I'm going to focus on these 5 questions, and that includes: what outcomes should I measure? How do we measure these outcomes? What are the attributes of a good quality measure? What about these PROMIS measures I keep hearing about? And then, most importantly, how do I use these measures in whether I'm doing clinical research, patient-centered outcomes research, or in doing clinical practice and improving care? Because of the broad nature of these types of questions, I've been given more time, thankfully, than other presenters. So my talk hopefully will be at 30 minutes, and I've set my timer to keep myself on target. So to start, this is a quote I heard from a conference a few years ago, and I think it really resonated with me. It was from a patient advocate. And the patient's quote, I wish I'd written that person's name down, but said, "Nothing about us without us." And through all the talks we've heard from Courtney and Amy, Cameron, Tracy, Laura, and others there, I think this is all emphasize the important point of the work we're doing, is that we can't do good work without engaging our patient population. And I'm thankful to Tracy for allowing me to use some photos from the 2019 OI Foundation regional meeting in Sacramento. I love these pictures because, again, I think it represents that the OI population or community is very engaged in this work. And from everything I've observed and seen over my years working with Tracy and with Laura, they want to be at the forefront to make sure we're answering those questions that are most important to themselves. And so, again, it's our job to make sure we capture their voice in the right and proper way. And as an example, about 2 or 3 years ago, a colleague of ours that works with Amy Cornelli, Dr. Amy Cornelli in our Qualcore group, Terry Sweezy, went to the Brittle Bone Disease Foundation And let's see, I'm going to move something out of my way so I can see what I'm looking at. So she went to the 13th Annual International Conference for OI in Oslo, Norway, and there Dr. Sweezy conducted 2 different 1-hour sessions with 15 adults with OI, focusing on 3 topic areas: key health issues, gaps in knowledge, and research priorities for adults with OI. If you want to know all the detail, is in the full detail is in the reference you see at the bottom of my slide here. But most importantly, I'm capturing just parts of information where Dr. Sweezy asked the participants, what are those things that are important to you that impact your lives? And so although we always know that things like brittle bones are a daily worry for the OI community, there are so many other things that are immediately in their mind that are impacting them. And so that's above and beyond fractures. We see things like breathing difficulties, hearing problems, GI distress, pain, depression, anxiety, and several others I don't have on this particular slide. In addition to just hearing about these symptoms and how they impact their life, we know that these symptoms also impact their functioning. And so what we see here for functioning here is we know that these symptoms impact their ability to move around for physical functioning, to do self-care, to exercise. These things have impacts on their ability to be successful in their careers, in their schooling, and in their relationships, both with friends, with family, and in intimacy types of relationships. And they further carried on to talk about how these functionings are limited, how these things also impact their overall quality of life. And so things like their mental health, their ability to be social isolation, well-being, and satisfaction with their quality of life. And so what I like about looking at all these particular symptoms impact functioning quality, all these things emerge through these important conversations that Dr. Sweezy had with just these 15 patients, adults with OI. And so the important point I want to make here is, if the field had such a narrow view that the only important thing that we should be looking at in our research is just the number of fractures, then I think we're missing out on the broad picture. And this is the broad picture. We need to recognize that these are all the different things we need to think about that we're capturing or measuring in some way, shape, or form, so we can see how their symptoms are impacted, how they impact functioning and overall quality of life. Therefore, when we think about how do we select our particular outcomes, there's a number of things that help inform what outcomes we measure in any particular research study. And so, as I have emphasized, again, we need to involve stakeholders, and most importantly, these are patient stakeholders, but as we heard from Courtney and from Amy, that these could include clinicians, researchers, payers, and so many other as part of that process to help figure out what those outcomes need to be for a research study. Most importantly, for any type of research study, obviously the outcomes you choose should be based on your study objectives and research questions. These questions are informed by having an understanding of what your intervention is going to be. So what is the mechanism of action? What exactly is being impacted by the intervention you're testing overall? And lastly, other things that can inform what outcomes you choose should be done on previous research. And if this is a clinical trial, it may be previous research might involve like phase 1, phase 2 studies, or it might be observational studies, qualitative work. So there's many other things that can help inform which of those things are most important to measure, and together they help identify what might be your primary outcomes, your secondary outcomes, as well as exploratory outcomes. So now that we've focused and we've had a lot of conversation about what outcomes we need to measure, the next question is, how do we measure these particular outcomes? And so I've already outlined, that there are symptoms, functioning, and quality of life that we need to consider. And along with trying to understand how we measure these things like symptom, function, quality of life, we also need to recognize that how we think about measuring these outcomes varies depending on our lifespan from birth to childhood, to adolescent, to young adulthood, and into older adulthood. And so when you think about the lifespan and thinking about how we assess symptoms, function, and quality of life, when you can take the lifespan into consideration, this has impact in thinking about what is this outcome we're measuring and what approach we use to assess these particular outcomes. So in thinking about the concept itself, let's take the example of physical functioning. Now, again, as we think about the lifespan itself, when we talk about measuring physical functioning, what physical functioning is or how it's assessed can be different if we're talking about physical functioning for a baby or a child versus thinking about how we define physical functioning for adolescent or young adulthood, and how we think about measuring physical functioning might be different for older adults. The same argument can be made for something like assessing quality of life. You know, what is quality of life for a baby? Might be just the comfort of being held and being fed and their diaper changed. But what defines quality of life for an adolescent would be very different from a young adult to an adult and older adult. Even if we went to a narrow construct like pain, you know, that might be something where you would think, well, you know, everyone experiences pain across the lifespan, and you would think that construct is pretty narrow and should be the same throughout our continuum. However, remember, for one of the most popular pain scales we use, which is this like a 10-point scale, you know, it goes from 0, no pain, to 10, worst imaginable pain. Well, if you think about worst imaginable pain, you know, what the experiences of a baby child is and what worst pain they've experienced could be completely different from what a young adult or older adult defines what the worst imaginable pain is based on experience. Now, as we think about moving from what this concept means and how that concept can vary over our lifespan, we also need to take in consideration about what is the approach we use to measure these constructs across our lifespan. And on the next slide, I'll talk about these different sources of information, but you can imagine we've talked about patient-reported outcomes as the gold standard here, but obviously, you know, a baby or a very young toddler might not be able to self-report these things. So where are we going to get information about someone's symptoms like pain or functioning when they're too young or when they're unable to provide that information? So again, we have to recognize there are different sources to provide this information. And so there are a lot of different tools we can use to look at how we assess things like symptoms, functioning, and quality of life. And what we recognize is for these type of concepts is we can't capture these things with like a biomarker, like blood levels, hair follicles, or whatever. We were unable to use those things to figure out what someone's fatigue or depression are, or their functional impact, or their quality of life. But what we do have available to us is something called a phrase used by the Food and Drug Administration called clinical outcomes assessments. And so there are a variety of clinical outcomes assessments we use, and that's why I show a toolbox, because we have different tools available to us to assess these type of constructs. The first one, which you've already heard us talk about, is what's called patient-reported outcome measures. These are surveys or questionnaires where the patient themselves answer the questions, and again, that's deemed as the gold standard. Another type of measure we might use is having a clinician report on the particular outcome of interest. Another source we might go to is a caregiver, someone who's very familiar with the patient, to report on the particular measure, and that's called observer report outcome measure. For certain types of especially functional domains, we have what's called performance outcome measures, and like for physical functioning, this might be like a 6-minute walking distance test or a grip strength test. For cognitive, it might be doing like memorizing words and repeating them back. And then there's a new source of information we're also trying to learn about as well, and these are digital measures, like your pedometer. Many of these things are captured on your now smartphone there, and so we call these sort of passively collected data, and we're starting to learn about how this might inform how a person's functioning is impacted and potentially quality of life. Now, so these are the different ways that and sources we can use to collect data about an individual's health and how they change over time. Just to sort of compare and contrast these things, I'm going to go back to our example of physical functioning. Often, as we've heard, ideally, the self-report or patient report would be the gold standard. However, there might be some times when either the patient's too young or too ill to self-report, so we might ask about physical functioning from a clinician or a caregiver. Now, in comparing and contrasting those three different sources, again, the patient has their own self-reflection experiences, so again, they're thought of as the gold standard here. However, their experiences are framed by their own particular experiences. If we go to outside sources than the patient talking about physical functioning, you might say, well, okay, the caregivers, they have a value-based perspective because they see that individual in the context of their individual day, in the context of how they interact with others, and that might be important. It can never replace the patient report, but it's a nice complementary information. And then you might also think about, well, clinicians can also provide a perspective because they see a lot of maybe OI patients, and again, they can compare and rate that person's physical functioning based on how, say, them compared to others as well. But we also know that it has a narrow window for which they've observed that particular patient. Again, staying along the lines of physical function, performance-based tasks are nice. Again, you could do grip strength, get up and go, walking and things like that. But performance-based tasks are very narrowly focused on specific activities and don't give you a sense of how that person is impacted holistically. And again, we have the digital measure. So again, each piece of information has their strengths. Each piece of information has their limitations. We never think that one is right and one is wrong, but they all provide some type of different ways of looking at how a person is feeling or functioning. Another key point I want to make here, is highlight this quote by a German physicist named Werner Heisenberg. And what Dr. Heisenberg says is, what we observe is not nature in itself, but nature exposed to our method of questioning. And I love this quote because it consistently reminds me that none of these measures we use are actually perfect. In other words, that none of these measures are absent of error. They all have some error. Even our laboratory test has some part of error associated. And so we need to recognize that while we're doing the best we can, we need to recognize that everything has some type of error, and so our goal is trying to get as reliable as measure as we can. And so given that, let's talk a little bit is what are the attributes we look for when we develop a quality measure? And so the source of information I'm going to use for this slide comes from the Scientific Advisory Committee of the Medical Outcome Trust. You see reference in the bottom of my slide. And the first thing we look for in any good measure is the measure's reliability. And there are different ways to assess reliability, but all of them together basically look at is to what degree to which an instrument is free from measurement error. The estimate reliability is bound between 0 and 1. 1 represents perfect reliability, which we'll never achieve. 0 represents no reliability. And so again, our goal is to be as close to 1 as possible to make us feel that we're getting consistent, reproducible data on that particular patient with the measure we use. The second aspect of any good measure is what's called validity. And in basic terms, this asks, does your measure measure what it's supposed to measure? So if I'm having if I propose my measure is a measure of physical functioning, then I would expect my measure to include questions if this is a PRO, things like, are you able to walk? Are you able to get up and down? Are you able to pick up things and things like that? So obviously I would look for the way that these questions are both capturing the content of interest or the outcome of interest, and then how well my measure associates with other existing measures to help inform that I'm getting a valid measure of what I'm supposed to do. The third aspect of any good quality measure is it needs to be responsive to change. And so this is critically important, especially when we do patient-centered outcomes research, because ideally you're measuring at a baseline assessment prior to your intervention, and you want to see how your intervention works. And if it does work, you would like your measure to be able to pick up on those changes over time. the fourth aspect, what we look for in a good measure, and this is really important and critical to be able to disseminate this information, which is what is the degree to which one can easily understand the meaning of the scores behind the measure. And so it's not simply just knowing, oh, what does a high score represent or a low score represent when we're measuring things like depression, pain, or physical function there. It's also understanding is, you know, if I see a change over time in an individual, is it a meaningful change? So obviously we might be able to get statistical differences between groups, but is that really meaningful from the patient perspective in terms of how this intervention is impacting their lives? The fifth way, we look at the quality of a measure, recognizing that either in the U.S. or broadly, you know, we live in a multicultural, multinational population, and so we need to make sure any measure we use is applicable and valid to all parts of our culture and diversity, as well as if we're doing multinational trials, we need to make sure that instrument is available in multiple languages that are and understandable. And then the sixth one I'm going to talk about today is, you know, we need also to be respectful of the respondents' time, participants' time, as well as administrative time. So this means that, you know, while everyone wants to ask our participants about all these different types of outcomes domains in OI, we can't bog them down with a 2, 3, 4 hour assessment. So we need to find unique ways to shorten our questionnaire and only focusing on those things that are important as part of our research study. In addition, we have to recognize is that there is administrative time, depending on, you know, we'd love to collect this data every day. We need to be respectful about what the administrative burden is to collect this data. In addition, there might be things about the measures themselves that might be challenging. Some questionnaires actually cost some money, and so you need to either build that into your budget or figure out other ways to collect this data through other types of measures. So now that I've talked about the quality of the measures, many of you who have done work in this field may have started to hear about this thing called the PROMIS measures, and this is going to focus more on the patient-reported outcome measures. So to contrast PROMIS, I'm going to start with talking about typical patient-reported outcome measures. So the typical way we classify part of our patient-reported outcome measures is whether there are generic measures, which means that they can measure symptoms, functioning, quality of life across different types of populations like the SF-36 can, or the numeric rating pain scale has been used across different populations. And so those are great for looking at the burden of disease across populations, but if you really want specific information on a population like OI, then there are what's called disease-specific measures, where they might include outcomes or questions that are much more relevant and directly important for a particular condition, disease, or some other population. And two examples are from the cancer field is the functional assessment of cancer therapies. For those of heart failure, the Kansas City Cardiomyopathy Questionnaire. Is there a disease-specific measure for OI? I don't work in this field enough. I've did some Google searching and haven't found one that's sort of well used across the field, but again, you all work in the field can probably inform me about those particular measures. So let's talk about PROMIS. And so to talk about PROMIS, this is an initiative that started back in 2004 by the National Institutes of Health with the goal to improve the assessment of self-reported symptoms and function and quality of life across a broad range of condition diseases. So PROMIS is considered a generic measure because it does measure these things across diseases. However, what makes it unique for a number of ways, which I'll highlight through my talk here, is that these PROMIS measures have undergone extensive evaluation, both using qualitative methods, for which Amy and her group are experts in, but also quantitative methods or psychometric methods to make sure that both the outcomes we measure are validly captured, as well as the items included there are relevant and are able to differentiate people up and down across the severity or of range of symptoms and functional status. I actually haven't done the Google search to go the exact number, but I know there's more than 1,000 publications out there for PROMIS that have used it in many different populations. And I want to point out Dr. Tozzi's work, where she's actually collected PROMIS data through the registry and has reported on its validity and reliability in the publication you see at the bottom of the screen. PROMIS does have a number of measures, both in the adult space and the pediatric space. In terms of the adult space, what I'm showing you here is we have divided the measures among physical health, mental health, and social well-being. Under physical health are things for the adult space like physical functioning, pain, fatigue, sleep, sexual function, GI symptoms, etc. Under mental health, we have such domains as depression, anxiety, cognitive functioning, self-efficacy, and other things like that. Social health, ability to participate in social roles, social support, social isolation, etc. On the pediatric side, again, we have our domains are organized under physical, mental, and social health. Again, we see a lot of domains that are similar in adults are similar in the pediatric space. So what differentiates PROMIS from other PRO measures? And so to think about this, I like sort of the analogy for PROMIS, I like to think of it as like an a la carte menu. And with this a la carte menu, you have the ability, using the PROMIS system, to choose which outcomes you want to measure for your patient-centered outcomes research studies. So if all you want to measure is physical functioning and pain, then that's all you need to measure. And there are PROMIS measures just for those two domains. If you want to measure fatigue, anxiety, depression, and sleep disturbance, and again, there are measures specifically for it. So you are not forced to have to measure a whole bunch of measures. You choose what outcomes you want to measure. In addition, PROMIS allows you to control how long the questionnaire is. And so, for example, for fatigue, we have 4, 6, and 8 item measures of fatigue. And the importance of the number of items relates to how reliable or how precise of an estimate you want of their particular fatigue, physical function, or et cetera as well. In addition, a strength of PROMIS over existing measures is you can choose what we call the short forms of PROMIS. And so, for example, you might want everyone to answer all 6 items of fatigue as part of your short, and everyone answers the same 6 items in your research study. But PROMIS has this other technology called computerized adaptive testing. And with computerized adaptive testing, it actually individually tailors, it selects items based on how a person answers each question. And so the strength of adaptive testing is that it administers the fewest number of items, but still gives you a reliable estimate of their pain, physical functioning, fatigue, or whatever your outcome you want to measure. And then lastly, for PROMIS, it's being used in a lot of different applications from research to clinical care settings. So let me explain a little bit about the PROMIS scoring metric. And so the PROMIS scoring metric is on what we call a T-score metric. The mean, I'll explain in a moment, is a mean 50, standard deviation of 10. And so the range typically for any PROMIS measure along this ruler, typically goes from 20 up to a score of 80 typically. And what's important here is what the high score represents more of the construct we're measuring. And so if we're measuring something like symptoms, a high score represents high symptom burden. If we're measuring something like functional status, a high score represents high functioning levels. And in addition, to give some more meaning to what this metric represents, the mean of this population, like 50 here, has some importance for PROMIS measures. And for most adult measures, the mean represents the mean in the U.S. population. And so if an individual person gets a score of 55, we know that they're about a half a standard deviation above the U.S. population mean. In addition, we have done work to characterize this continuum from 20 up to 80 to represent different levels of symptom severity. So, you know, if it's a symptom like fatigue or pain, a PROMIS score of 55 or less is in what we deem the normal range. A score from 55 to 60, mild. 60 to 70, moderate, and 70 above is severe. We can also do the same thing for functioning as well, where we have divvied up the categories based on what presents normal, mild, moderate, and severe limitations. And so the question was asked of me is, how can we make PROMIS work for the OI community? And so there are a few ways we can make this work. So the first thing that I recommend doing is, to help move our field forward for OI research is, number one, it would be good to have university accepted or something close to that core set of what outcomes are important for the OI community. And I have a question mark here because maybe this has already been done, at least it's been talked about, but is there buy-in that whether it's physical functioning, pain interference, and sleep disturbance, maybe those are the 3 core things we want to measure in all research studies in the OI community. That doesn't mean you can't measure other outcomes, but it might be important to set these. That way you have consistent outcomes across research studies. The second thing to consider is, now that we know what outcomes we're measuring, is how do we select the relevant measures? And again, PROMIS has the ability of providing those measures for you. And you can go to the healthmeasures.net website right now. Hopefully you won't do it during my talk, but you can go ahead and use off-the-shelf forms or adaptive testing right now, even starting today once you have IRB clearance. We also have the ability to create OI-specific short forms for each outcome, and this would be working with patients and other advocates and stakeholders to go down and go through, like, for example, the physical functioning questions and choose those items that are most relevant and most important to reflect physical functioning for the OI community. I have this sort of time capsule here to represent this. Does take some time, and it's sort of in green because it also takes money to do that. Now, if there are not PROMIS measures for an outcome that is of interest to you, there might be an example that might be financial burden, might be of interest to the OI community. There is not a PROMIS measure of financial burden at this time, and so you might have to go out and find an existing measure if that does exist, or we might need to create new measures for those outcomes not captured, and again, that takes time and funding. The last thing we can do is I've talked about those different scoring algorithms for PROMIS, and so what might be something of interest to the GI registry is to collect population-based norm scores, to use the registry to identify what are thresholds for different thresholds for mild, moderate, and severe function, symptom and function levels in the OI community. Also, we might work with the community to figure out what represents a meaningful change going up and down the PROMIS T-score metric. And so lastly, and I'm sorry I'm going quickly, but I want to make sure I'm respectful of everyone's time, is how do we use these measures in clinical research and practice? And so when we do patient-centered outcomes research, we recognize that we're not just interested in how the efficacy of intervention or its effectiveness, we're also interested in balancing that with the safety or harm. And I think that whether it's patient-reported outcome measures or any other kind of clinical outcome measure we use, those can be used to evaluate that trade-off between efficacy and safety. If you want good advice about how to use patient-reported outcome measures in a clinical trial, I do recommend you go to the Proteus website down here in the bottom right here. They have a lot of different guidelines and tools to use, how to use PROs in clinical trials. And they include such recommendations like how do you determine what's the primary, secondary, and exploratory endpoint in a study, and which ones should be captured through patient report or some other type of source. They talk about how to select the most appropriate measure for an outcome, which follow those guidelines I just outlined for you. They talk about how to think about how often to collect data. You know, obviously you want a baseline assessment of where people are starting, but how frequently do you assess these things, ideally matching up and collecting this data at points when the patients are symptoms and functioning going up and down. That way you can capture that trajectory over time. Fourth, what are best practices for maximize data completeness, because anytime there's missing data, that impacts your ability to make good inferences from your study. Fifth, it talks about the importance of your statistical analysis plan and sampling plan, issues of how you're going to address missing data, maybe using imputation measures, or how you determine what's the most meaningful change to determine what isn't enough, who is a responder or non-responder to your intervention. Importantly, how to write up data using the patient-reported data and publish in a timely manner to be respectful of the patient's input, and then how to disseminate those results as broadly as possible to make hopefully impact on policy. On the opposite side is how we use patient-reported data in clinical practice. And over the past couple of decades, all healthcare practices have moved to electronic record systems. And these electronic medical record systems like Epic usually have a patient portal for which communications are done with patients. And through that portal, we have the ability to do electronic patient-reported outcome measures. And importantly, in this day and age of telemedicine and telehealth, we have the ability to collect patient data directly from patients from their home or from the clinic, and that data gets linked into the electronic medical record and combined with clinical data to provide a dashboard both for the patient and clinician to help inform symptom management and make referrals. But as for collecting data individuals, we can also collect data in our warehouse, aggregating across multiple individuals to be able to allow us to do both quality improvement at local clinics and hospital systems, but also to do comparative effectiveness research or patient-centered outcomes research. If you want guidance on how to use PROs in clinical practice, PCORI provides a great, over 100 pages guideline that's linked at the bottom of your page here to good sources of how to use PROs in clinical practice. And they address important questions like, what is the governance structure that's appropriate for how to prioritize the integration of PRO measures in the EHR system at a local clinic or a hospital system. They addressed what kind of proper training one would need for the clinicians and administrators to be able to employ and use those measures. How to to figure out which patients should be completing the measures. Should all patients complete questionnaires, or should only patients at risk should be completing these questionnaires? What outcomes should we be measuring, which may be different in clinical care than in research? How to select the appropriate measure using those guidelines I've shown to you. When and how often you should collect data for improving patient care. And this is not just at the clinic encounter, but between clinic encounters, it might be important to collect this data because what we might find is the patient's getting worse in between clinic visits, which isn't represented at the clinical encounter. Importantly, we need to figure out how to present or visualize data to doctors and to patients to help them understand what the PRO data means and whether they're doing better or worse. To guide clinicians about how to act on data when it shows is problematic in terms of pain or depression or other things like that. And then lastly, what are those ethical and legal issues you need to consider, because we are creating an audit trail, and when a patient is, we need to make sure that the patient's data is not only safe and secure, but also we need to recognize if patients from their home reporting extreme pain or extreme depression, we need to make sure there are processes in place to be able to respond to them in a timely manner to provide particular care. So thank you for your time. And my last 2 points is, I think there are a lot of different options for us to integrate PROs and other measures in patient-centered health outcomes research. And most importantly, there are opportunities for the OI community to embrace this type of work to be able to maximize its decision-making to help improve care and reduce burden and disruption. So with that, I'll stop there and open up for questions.
Dr. Reeve, thank you so much for your very informative talk. So I'm going to say we probably have time for one quick question, so we'll try to be as quick as possible about this. One thing we have here is for the PROMIS measures, are parent proxy measures valid and reliable for accurate gathering? And for what age ranges might pediatric self-report be more reliable and valid?
Great question. So that's correct. In PROMIS, there are both self-report or patient-reported measures, and there are caregiver or proxy-reported measures. Those proxy, it's called the parent proxy measures, are only developed for the pediatric populations, and so there is not a proxy report for the adult populations. The self-report or pediatric self-report measures are validated for children between 8 and 17 years of age. And for the parent proxy measures, those have been validated for children between 5 and 17 years of age. However, there has been work recently by the ECHO initiative where they've started to move that age limit from down to age 3 for many of the parent proxy PROMIS measures. For a select few of those pediatric proxy measures, maybe down to age 2 or 1, but definitely I think they're working it down to age 3. Now, the important thing here is that you know, it is important to capture that proxy perspective, but what I want to discourage is don't assume what the proxy report is the exact same of what the child self-reports. So when you can collect children's report data, that would be the ideal. But when you can't assume that the parent proxy would be the same value as what the children report.
Great, thank you so much. So thank you so much, Dr. Reeve. Dr. Tosi, you're going to jump in?
Yes, I am. Bryce, that was extraordinary, truly extraordinary in its thoughtfulness, range, etc. And thanks so much for including such great references for everyone. Let me speak to a question that has come up on the chat line. We had sent out some references earlier from Dr. Corneli's work, and we will be gathering up these references and sending them out to folks who have been participating in this program, just to make it easier for you.